And I would like to welcome everyone to the Australia-New Zealand Academy for Eating Disorders webinar on male eating disorders, presented by Stuart Murray, who's a clinical psychologist in San Diego, California. So really thank you for being available today, Stuart, to do this talk. I realize that it's probably a bit after hours for you, so we really appreciate you being available to do this. And before I introduce Stuart, I just want to do some housekeeping matters and let you know some things about the webinar and the computer system and all that. So this can be listened to via your computer speaker or by dialing in on the phone number on the screen. If you use the phone connection, you'll need to turn down the volume on your computer or you may get an echo. You can do this by clicking on the bottom left-hand corner of the screen. If during the webinar you notice that your screen has frozen, you can refresh it by clicking the blue circle with the white X in the top right corner of the screen. Then click the orange button to reload the conference room in your browser. And this does happen from time to time. So if suddenly Stuart's not moving at all, then you might want to try doing that. And for other technical difficulties, you can make a note of the numbers on the screen to dial in for technical assistance. Please type your questions and comments at any time in the chat bar on the bottom left-hand corner. Stuart's going to leave some time at the end for some questions. Okay, so Dr. Stuart Murray is a postdoctoral fellow at the University of California, San Diego, and he also serves as a director of the National Association for Males with Eating Disorders and is co-chair for the Academy of Eating Disorders Special Interest Group on Male Eating Disorders. He's been very busy. He's authored more than 60 scientific articles and book chapters and has presented internationally on this topic. And really, I'm especially pleased to be hearing this talk here in Nelson. We've had quite a number of males present, and often they present very late and with some fairly serious medical complications. So I'm really interested to know how we get people more recognized earlier within the primary health sector. Yeah. So without further ado, welcome, Stuart.
Thank you.
Without further ado, Stuart. Are your slides coming up on the screen?
No, they're not yet. And you just dropped out a little bit on the volume as well. I could see your lips move, but no volume. So, okay, here we go. I can see my slides. Thank you.
Okay.
All right. So thank you. Thanks, Leslie. And before I start, I do want to extend a special thank you. Can I start, Leslie? Is that okay?
Go for it.
Okay. Yeah, I just wanted to extend a special thank you to Leslie and Jeremy and Sloan and the organizing committee for extending the opportunity to me to take part in a really awesome webinar series with some quite esteemed company. And it's a very special invitation for me after having done my PhD and my doctorate in Sydney and having many of my mentors and close friends still in Australia and having leaned on ANZAED to essentially in completing my PhD. So this is a very special honor for me. So I want to thank the organizers for the opportunity. And as you said, Leslie, I'm going to talk about males, eating disorders in males specifically. And I'm going to try and talk for about 30 to 40 minutes and give a bit of a brief overview of the area. I think that there's too much detail across too many domains to give everything the attention it warrants. So I'm going to deliberately attempt to give an overview and leave time at the end for questions where we can zoom in on any of the areas that come up during the course of the webinar or anything that doesn't come up, in fact, too. So hopefully we'll have about 10 or 15 minutes at the end for questions. But before, the first thing I wanted to do was provide a historical overview of eating disorders in males. And a surprising fact to many is actually that we've known about eating disorders in guys for about as long as we've known about eating disorders, period, full stop. And the first description of what went on to be termed anorexia nervosa by Richard Morton depicted nervous food consumption that occurred in the sort of context of sadness and anxious cares. And he described this syndrome in two people, one female and one 16-year-old male. And then a couple of hundred years after that, in two really seminal pieces of work for the history of eating disorders by Laseg in France and Gull in England, who coined the term anorexia nervosa, both of these describe the family dynamics of afflicted male patients. And we're very clear on the notion that this illness did occur in males, anorexia specifically. And an interesting tidbit actually is how the term anorexia nervosa was decided upon, and it was actually a direct reflection of the fact that this illness does present in males. The competing name for this illness at the time was anorexia hysterica, but it was thought at the time that males couldn't be hysterical, which we now know to be false, at least in my case. And so it was termed anorexia nervosa to represent both genders who are afflicted with this illness. And so after these really key seminal pieces, something kind of strange happened, and we really neglected males with eating disorders who kind of fell off the radar for a long, long time as our field advanced and learned a lot about eating disorders in females. And the next, or the first, I should say, real study shining a light on this syndrome in males came actually by Peter Beaumont's group in 1972, who spoke about the occurrence of anorexia nervosa in males. And that's really the point at which we started to claw back some knowledge and cover some ground on this syndrome in males, which was very slow to pick up speed. Unfortunately, the absence of males from the field until this point really marginalized eating disorders in males who were deemed rare or atypical and were excluded from controlled trials. And these were the trials that went on to inform the development of diagnostic criteria and went on to inform the development of treatment modalities, engage the efficacy of these modalities, and even develop tools of measuring symptom severity, all of which didn't include males, and most of which actually had a male gender as an exclusion criteria. So inadvertently, we kind of developed a female-centric lens in documenting eating disorders in our field. And so now we're sort of covering ground as fast as we can, and it's about the most exciting time there has been to be a researcher interested in male eating disorders, and probably about the most hopeful time it's been to be a clinician working with male eating disorders. We know now much, much more than we ever have about this syndrome in guys. However, there are still a number of myths that do still abound in working or in conversing with colleagues about eating disorders in guys. So I want to take a few moments just to try and dispel a few myths which you may have come across or you may come across. And the first one is this notion that eating disorders in men are exceedingly before the mid-1950s, it was even thought that males couldn't get anorexia nervosa at all. There was no direct endocrine equivalent of the amenorrhea criterion, and so this syndrome was thought to not be applicable to guys. And at best, it was acknowledged that, yes, dietary restriction can occur in guys, but it's not serious. It doesn't really include the core psychopathology that we see in females, the core drive for thinness and fear of weight gain. And it's probably more likely to be a result of some other psychiatric illness with a sort of secondary dietary restriction symptom. And even eminent psychiatrist Maria Salvini, who did a lot of work in systemic family therapy, whose work now is really visible in what we call FBT, was one of the proponents of this illness not being applicable to guys. However, as more and more guys did trickle through to treatment centers, we had to revise this notion of them being non-existent. And it was sort of decided, it was found and illustrated that guys do have eating disorders, and anorexia in particular, although they were exceedingly rare and made up about less than 10% of all cases, which kind of indicated their exclusion from these trials because they were the outliers in all of the trials. So they continued to be excluded from a lot of controlled trials, and the distance between the research field and the diagnostic criteria and treatment modalities from guys was sort of getting bigger due to their exclusion from these trials. However, we have some really good epidemiological data now which really disproves this misnomer, I guess. And some data out of the States, the National Comorbidity Survey, illustrates that 25% of anorexia and bulimia nervosa presentations are male. So this is not an insignificant minority anymore. This is a quarter of all AN and BN cases, which is substantial. When we look at binge eating disorder, we see a pretty comparable gender distribution. And again, in selective eating disorder, in pre-adolescent ARFID, or what's now termed ARFID in DSM-5, we see slightly more boys than girls afflicted. So we are seeing this increasing prevalence, this increasing presence of males in eating disorder clinics. And that's really corroborated by what we see in the community. And some great work that Deb Mitchison and John Mund have been doing in South Australia show really two really key findings. The first being that for the very first time, the rates of disordered eating practices are increasing faster in guys than they are in females for the very first time. So the males are catching up. And by disordered eating practices, their group referred to dietary restriction and purging behaviors. And the second really important finding of John's work is that the result of these disordered eating behaviors cause an entirely comparable impairment to quality of life as to that reported by females. So we see the same impairment, the same illness burden. So we're seeing this increasing prevalence of guys and the increasing burden that goes with it. And this is corroborated clinically as well with what we see in specialist clinics like the one at Westmead. Sloan's group reported that the incidence of pre-adolescent cases is increasing. And so when we take a step back and hold this myth that these disorders in males are rare, and we take a step back and look at this data, there's not really much to substantiate that anymore. We see that pre-adolescent eating disorders, they're pretty comparable across genders. And the eating disorders which aren't specifically oriented towards a thin body ideal, binge eating disorder shows a pretty comparable split across males and females. And then when we get to adolescence, something seems to happen. And we see this preponderance of female as opposed to male cases of anorexia and bulimia. And whilst we're seeing more male and female cases, we still see 3/4 female, which begs the question, what's happening in adolescence? Is there something happening that insulates guys from eating disorder concerns in adolescence, given the comparability pre-adolescent? And the other thing that I think is worth considering here is the genetics and the neurobiology of eating disorders and the emerging imaging data and the emerging genetic data should suggest that the 50 to 80% of the risk of developing an eating disorder is conferred by genetics. And there is no evidence at all that this genetic risk skips males. And what's in fact much more likely is that male eating disorders present a little bit differently. I'm going to go back to some community-based epidemiology data here in the States, which shows that about 6% of adolescent boys in the community report extreme concerns with their muscularity and endorse dangerous dietary practices and endorse dangerous practices to manipulate or modify their level of muscularity. So we're going to try and hold on to this in a second, this notion of muscularity. Nevertheless, though, the bottom line is that 25% at the minimum of all cases are male. And I think that if we enhance the sensitivity of our questions and our diagnostic criteria, and we go some way towards destigmatizing this illness for guys, I wouldn't be surprised if that 25% swelled fairly substantially. The second myth that I want to try and quickly touch on is this notion that homosexuality in males is a direct risk factor for the development of eating disorders. And papers as recent as 10 or 12 years ago, would state that, or did state, that if you had a male patient with an eating disorder, it should be assumed that there was some level of sexual confusion. And another group suggested that if you have, across any psychopathology, a gay male amongst your client, they should be screened for an eating disorder, which is pretty nuts, right? So we did a study looking at the sort of the truth behind this and how how firmly they stood up under scrutiny. The one thing that is robust is that there's no representation of eating disorders in the gay male community. And we don't know why that is. There have been hypotheses put forward such that males, when selecting male partners, place more of an emphasis on physical appearance, so there's perhaps a greater objectification. There's also more of a stigma resistance in this population, so perhaps eating disorders don't hold the same stigma as they do in non-gay cultures and communities. Nevertheless, what we found when we tested this empirically was that sexual preference had pretty little to do with eating disorders. And we did a study looking at what mediated the divergence towards thinness versus muscularity-oriented eating disorders. So within the context of body dissatisfied guys, what caused some to lean towards anorexia nervosa and thinness type presentations, and what caused others to lean towards muscle dysmorphia, which we'll talk about later, or muscularity-oriented kind of concerns. And we found that sexual preference had very little to do with it, and it was more gender construction. So the guys with anorexia nervosa reported more adherence to feminine gender norms. They weren't any less masculine, but they endorsed greater feminine gender norms. And the guys with muscularity concerns endorsed greater masculine norms and weren't any less feminine. And we think that's pretty much confounded all of the work that went before this. And we've really debunked this myth that homosexuality is a risk factor for eating disorders in guys. And the third myth, just quickly, is this notion that eating disorders present similarly in males and females. The core concerns are the same, the symptomatic behaviors are the same, the cognitive rationale and the cognitive drivers underpinning the symptomatic behaviors are the same. And the inference from that assumption being that the same treatments can be applicable, the same diagnostic criteria can be applied and equally effective. And when we look behind the surface of this myth, we start to see some pretty apparent and immediate differences between male and female presentations. The first one, probably the most apparent one, is there's a later age of onset for eating disorders in guys. We see females onset typically early adolescence, and males most frequently onset towards late adolescence. And that may be due to the impact of pubertal timing, and in females, the development of hips and boobs move you away from a female ideal body, and the surge in testosterone as guys approach puberty perhaps support a movement towards a male ideal body. That's not been substantiated, only postulated. But nevertheless, the other obvious difference is that guys have a higher BMI, which makes illness detection a little bit more tricky in guys. And there's also a greater history of overweight and obesity in guys. And there's also a more diverse array of psychiatric comorbidity. And these guys seem to be more afflicted across the board. You know, a really important difference to note clinically is that there's greater rates of suicidality amongst guys with eating disorders over females. Now that's very important to note, because when guys are likely to be, they're more likely to be effective in attempting suicide than females, and they're also more likely to use violent means to attempt suicide, which is really noteworthy in an illness like anorexia nervosa, which features suicidality and suicide rates 57 times higher than those without anorexia nervosa. So this presents a real sort of caution in working clinically. The other thing to consider, as Leslie was saying earlier, is that these guys are less likely to seek treatment. There's a huge stigma that still applies, perpetrated by the general community, by us as professionals, and by men themselves with eating disorders, that really presents a huge barrier to seeking treatment. And that means that guys don't get recognized quick enough. They fall into treatment at a later trajectory of their illness development. They're more entrenched, and they're more medically compromised, and they're probably more treatment resistant to that stage of illness severity. So those are some demographic differences. However, the biggest difference, I think, is worth taking a step back and looking at these sort of trends socioculturally. And when I think about eating disorders, I'm really hard pressed to think about any more gendered or sexually dimorphic psychiatric illness across the board. And I think that's because trends portrayed to men and women respectively. And when we think about models of maintenance of eating disorders, I'm going to borrow Chris Fairbairn's model, of the transdiagnostic model of eating disorders, and what that model will tell us is that the core pathology is an overvaluation of shape and weight, and that symptomatic behaviors are an attempt to mitigate the effects of eating on either shape or weight. But here's a caveat. What implicit in that assumption is that the body that's overvalued, the shape that's overvalued, is thin. And also, to extrapolate that out further, the symptomatic behaviors of an overvalued thin body are very different if the body type that's valued or overvalued is different. So let's have a look for a second at the socio-cultural trends on body ideals portrayed to women currently in Western society. So here's Keira Knightley, and here's Miranda Kerr, the Australian supermodel. Very thin, absence of body fat, almost emaciated body types. And you know, if we ask a college-age Australian or New Zealand student whether how they feel about their body, if we assume that they're normal weight, I'd bet most likely they'd say that they feel like they're overweight, and sharing that as well. They might tell us that they've tried to lose weight. They might tell us that they've dieted to try and lose weight. They'd almost certainly tell us that their ideal body was thin. And when we think about the same question in guys, we get a very different answer. And here is the current body ideal portrayed to guys in Western society. Again, this is Hugh Jackman, Australian actor, and Ryan Reynolds, American actor. And if we just eyeball that, the array of disordered eating behaviors that stem or that emanate from an overvaluation of this body type would be very different than if you're pursuing this body type. And similarly, if we ask the same question to guys in Australia and New Zealand, they might tell us that they think, even if they were average weight, they might tell us that they were underweight, and they might desire a weight gain. And some very profound data, I think, from the Harvard group who studied muscle dysmorphia tells us that most guys, on average, would sacrifice 4 or 5 years of their life for an extra inch on their biceps, which really goes some way to conveying the importance of muscularity to guys, or adolescent guys, at least at the moment. And so when we ask these guys, hypothetically in Australia and New Zealand, they might tell us that they've tried to gain weight, gain muscle. They may be taking supplements. They may be engaged in gym routines. They'd almost certainly tell us that their ideal would be two things: lean and muscular. And that's the dimensions which run central to male body image. This notion of muscularity, which most simply put is how much muscle can you pack on your frame. And the second one is leanness, in that the absence of body fat promotes a greater visibility of muscularity. So there's almost two dimensions crisscrossing for guys. And the other key differences in guys, I think, is that the concern is most centrally focused on upper body regions, the biceps, the shoulders, and the pecs, and the six-pack. And when we ask girls, we most likely hear that the main area of concern is the thigh gap, the thighs, the butt, and maybe stomach and hips as well. So there's this sort of, when we consider socio-cultural trends, there is this sort of increasing divergence of what we value. And this notion of muscularity and the importance of muscularity runs central through pretty much every diagnostic category we see with eating disorders, and even through non-eating disorder diagnoses. So let me start with, well, I'm jumping ahead of myself here. This is an image of the Hollywood heartthrobs of yesteryear. This is Clint Eastwood, John Travolta, and Tom Hanks. And these are really pretty attainable body types. One might not need to engage in disordered eating behaviors or even considered efforts to attain a body type like this. This may not cause the immediate reduction in body satisfaction that these images cause. And this really shows us the increasing commercial value of muscularity for guys, and the increasing objectification of the male body, and how central muscularity and lean muscularity is to males in their construction of body image. And as I was saying a second ago, this one's pretty central throughout most diagnoses, certainly that I see in clinical practice. So I'll start with anorexia nervosa. The core symptom is, of course, a fear of weight gain and the drive for thinness. And if you didn't have that, you would by definition not have anorexia nervosa. So behaviorally, guys with anorexia do endorse these behavioral practices. The caveat, though, is that oftentimes the cognitive driver of those behaviors may differ slightly amongst men. And I've seen a great many guys who report the attempt to lose weight in promoting greater leanness as opposed to greater thinness per se. So they may be more oriented towards wanting to look defined and toned as opposed to thin per se. So questions around asking them if they want their stomach to be hollow may not be the right question to ask versus if they want their stomach to be toned or lean or defined. Other symptomatic differences in guys with anorexia, as I mentioned earlier, BMI won't be as low, and the removal of the amenorrhea criterion has made diagnosis a little bit easier for guys, and the removal of a weight criterion has also facilitated that. The criterion now is a failure to maintain a developmentally appropriate weight, as opposed to a BMI of 17.5 per se. So again, as Leslie was saying, though, that these guys often seek treatment at a later stage of illness and are more medically compromised. So we as a field ought to enhance our ability to detect these illnesses as fast as we can, because perhaps the most striking finding on males with anorexia is that although the overall mortality rates are pretty comparable, the males who die from anorexia die much quicker than females with anorexia. So when we consider that alongside the finding that males seek treatment much later in their illness, this is a really dicey subject matter with some pretty grave implications. And sort of as an illustration of our challenges in indexing symptoms and symptom severity in males with anorexia, a colleague of mine, Ali Darcy, did a really nice study looking at clinically diagnosed males and females with anorexia nervosa, all in treatment, all clinically severe cases. When they completed the EDEQ, the guys looked much less severe than the females, and they, in fact, almost didn't look eating disordered at all, which baffled Ali in a group because she was seeing these guys behaviorally in clinical practice, but on paper they looked very different. And anecdotally, what the guys who took part told her was that these questions really aren't relevant to me. When you're asking questions about thinness and other questions I can think of on the EDI, about hips and buttocks and things like that, really don't resonate with guys. And so we have a great many guys falling through the cracks because the cognitive drivers behind their behaviors differ. And that's very true in the context of anorexia. And as a result, we might be well served to develop slightly nuanced treatment approaches. And a paper that I read recently actually postulated that treatment should be gender specific for eating disorders, that guys should have a completely different approach to treatment than females. And I don't agree with that. I think the first port of call, whether you're a male or a female, is weight restoration, paramount importance. But I do think there are some key differences that need to be addressed in males. And the first of those being stigma. And although there are sort of public health and prevention policy efforts at destigmatizing eating disorders, there's no treatment modality that really focuses on destigmatizing the experience of eating disorders in guys. And I recently ran an all-male eating disorder group here at UCSD. And the first question I asked everybody in the group was, what's been the biggest challenge presented to you by your gender in the context of an eating disorder and treatment for an eating disorder? And every single one in the group said the stigma, this notion that I'm ashamed to have an eating disorder, and if it gets out, my friends won't be my friends anymore. Some people have had experiences being sort of shushed away from primary care physicians because males don't get eating disorders, which really drives these guys further underground and further into the medical complexity that later stages of illness can breed. And they also felt like less male. In a way, these guys are often the only ones in treatment centers, and they feel less male. And so I think the notion of gender constriction is a really important topic to convey as well. And we, one of the studies that my group did looked at two biologically male transgendered eating disorder patients. And these guys, when their gender identity oscillated periodically, and when they adopted a female gender identity, their eating disorder presented as classic anorexia nervosa. And when they adopted a male gender identity, they presented as classic muscle dysmorphia. And this really showed us how one's body can really embody gender identity. And that really holds true in treatment for guys as well. It's often a very challenging traverse in terms of negotiating your masculinity under the umbrella of what's still termed a female illness. And so that often takes a pretty central part of the work that I do with guys. One of the other focuses I think that's a little bit different in treating males with anorexia nervosa is the focus on exercise. And the exercise is often the first symptom to crop up, even before dietary restraint in some cases. It's the last symptom to remit, and it's the first symptom to relapse. And this link with greater emotional regulatory features in addition to the shape and weight purposes, guys seemingly have a less diverse array of emotional regulatory strategies, and exercise is a very central one in anorexia nervosa for males. So we often really spend an extended amount of time working on exercise and normalizing exercise amongst males with anorexia nervosa. I'll move on to bulimia, and unfortunately there's been strikingly little done in the area of male bulimia nervosa. Very little at all. What we do know, though, is that men are less likely to engage in typical purging behaviors. They're less likely to use laxatives, and they're less likely to self-induce vomiting, and they're much more likely to use exercise, to use supplements, protein supplements and things like that, dietary supplements, and they're much more likely to use things like steroids, which we'll talk about in a couple of minutes. One of the things which isn't in the literature at all, but which I encounter a lot in clinical practice, a whole lot, is this notion of delineating binge episodes from cheat meals. And cheat meals, for anybody who's not familiar, is this notion that males, when usually adopting a muscular goal, a muscularity-oriented goal, endorse a very restricted and rigid diet, and periodically engage in what they term cheat meals. And these meals are often an objectively large amount of food. They're very often met with immediate compensatory behaviors, and either are met with reinvigorated dietary restriction or reinvigorated efforts in the gym. But the only difference, and this sounds a lot like bulimia nervosa for me, the only difference is this loss of control criterion, where guys engaging in cheat meals, it's almost like a socially sanctioned occasion. And it sounds very similar to the EDEQ question of planned binge episodes. So delineating these binge episodes from cheat meals is a very difficult thing to do in clinical practice as applied to guys with bulimia nervosa. I think it's strikingly similar to pretty classic bulimia nervosa. It's precipitated by intense dietary restriction, and it's followed by immediate attempts at compensation. And it's an objectively large amount of food, and it's a large amount of prohibited foods from what's normally incorporated into their diet. So that's bulimia nervosa. Sorry, you guys, I have twin daughters and one is waving at me in the background. I want to move on to muscle dysmorphia, and we've been speaking a lot about the centrality of muscularity and muscular concerns in guys with body dissatisfaction. And this is probably the archetypal muscularity-oriented eating disorder, even though it's not yet recognized as an eating disorder. This was initially termed reverse anorexia in recognition of the conceptual striking similarity to anorexia nervosa, but the symptoms were expressed in just the opposite direction. So these guys would often perceive themselves to be too small, and they would fear weight gain as opposed to vice versa. And that was unrelated to their actual physique. These could be Herculean guys, or they could be normal guys, they could be overweight guys. This isn't dependent on one's body type, only the cognitive drivers of the behaviors. So the core symptom of muscle dysmorphia is this pervasive fear of insufficient muscularity, and this notion that one can never be either muscular enough or toned or defined enough, which causes immense anxiety and distress, and that there are reports of guys living in their parents' basement and being so ashamed to come out due to their apparent or perceived lack of muscularity. And the associated symptomatic behaviors relate very much to compulsive exercise and weightlifting behaviors. And this is preferred over and above almost all other areas of life. And I recall a guy who tore his rotator cuff, a weightlifting injury, tore it, was in immense pain. And when working out whether to follow medical advice and stop weightlifting for a while or continue, he determined that the perceived pain of losing muscularity or potentially losing the muscle mass that he'd worked so hard for was more aversive than the physical agony of training with his torn rotator cuff. So he continued training and did himself a great damage by doing so, but couldn't desist from this training regime. The other really essential feature of muscle dysmorphia is disordered eating behaviors. And I'm going to skip ahead a slide and then come back, if that's okay. My group has started to develop this notion of, started to expand upon the notion of muscularity-oriented disordered eating. And what that really pertains to is an eating disordered profile which emanates from an overvaluation of a very muscular and lean body type. And these behaviors include overregulated protein consumption and fastidiously calculated protein consumption, with the idea being that the branched chain amino acids can maximally support muscle growth. And so there's this fastidious calculation. Guys weigh themselves very frequently, not because they have weight concerns. The data shows us that guys are more concerned with their shape rather than the weight on the scales. But the weight on the scales is useful in that it allows a determination of how much protein they should eat per day to be maximally positioned on the curve of anabolic muscle growth. And some arbitrary rules are followed, like 2 grams of protein per pound of body weight. So guys go as far sometimes as weighing themselves daily to work out how to be on the right side of the sliding scale to maximize their muscle growth. The other core feature of this muscularity-oriented disordered eating is the restriction of dietary energy and the restriction of carbs and fats. Now, we don't know the medical effects of a vast amount of protein consumption. We don't quite know how that affects the renal system, for instance. The animal studies suggest that it's pretty dangerous, but we don't know yet for sure. But the restriction of carbs and dietary fats is pretty comparable to what we see in male anorexia nervosa. So a study I did with a revised scale to measure eating pathology in men with anorexia, which we thought might be more applicable, and the same for muscle dysmorphia, we found that men with muscle dysmorphia engage on more restrictive diet and more dietary restraint than men with anorexia nervosa. And that's a super important finding because dietary restraint is the core symptomatic feature of anorexia nervosa. And these guys with muscle dysmorphia or muscularity concerns endorse a greater or at least a similar degree of restraint. And deviation from these dietary plans can be very anxiety provoking. And I've heard stories of people refusing to go to their best friend's wedding because they can't take a chicken and Tupperware dish to the groom's table, or setting your alarm several times in the night to wake up and drink a protein shake to be maximally placed to support maximum muscle growth. So there's a real degree of investment that can develop in these kind of behaviors that ordinarily would fall through the cracks. There's no diagnostic criteria that can support or even relate to these kind of behaviors. But are they disordered? I mean, we think so at this level. The other thing that we see is this fastidious use of supplements, intense anxiety if you run out of supplements, and we see anabolic steroid use as a very prevalent correlate of muscularity-oriented disordered eating. So I'll go back to this slide about muscle dysmorphia, and we just touched slightly on this notion that there's intense anxiety and guilt if either an exercise or dietary regimen is deviated from. and there's this intense body disguising and avoidance that we see in what we call the classic eating disorders, anorexia nervosa. So the question that my group's trying to answer at the moment is muscle dysmorphia an eating disorder? And is this better placed to recognize the male experience of eating disorder, which we know is increasingly concerned and oriented towards muscularity? And that's a simple question with a not so simple answer, unfortunately. We don't quite know, or we're not in agreement as a field as to what constitutes an eating disorder. I mean, does this feature an overvaluation of a particular body type? Yes. And does that overvaluation breed an array of shape, exercise, and eating behaviors? Yeah, it does. And does it centrally feature disordered eating? And we think it does too. And there's a case study that we did looking at a guy with muscle dysmorphia, and we followed him throughout the holy month of Ramadan. This Muslim chap was fasting, and he, as per Ramadan protocol, would break his fast every night, but would fast during sunlight hours. Now, his exercise regime did not change at all, only his diet plan changed. And we initially saw intense anxiety right away, and intense efforts at compensation with more gym time. And then on about day 4, he broke his fast and said, I can't take this. I can't live without the protein that's going to support my muscle development, and I can feel myself losing the muscularity. And so he broke his fast. So that really shows us the centrality of eating practices in determining symptom severity, because his symptomatology went through the roof when his dietary regimen was changed. And the other thing that we're sort of slowly learning about muscle dysmorphia is the genetic and the familial aggregation between anorexia nervosa and muscle dysmorphia. And we see a huge degree of transdiagnostic crossover. We more than a third of guys with muscle dysmorphia have a previous diagnosis of anorexia nervosa. And the Finnish twin cohort study, I can't recall the name, demonstrates very clearly that male co-twins with anorexia feature co-twins with intense muscularity concerns, and that's very common. So we're starting to slowly see this familial aggregation of these kind of symptoms. And perhaps the other thing worth noting is we just did a study and asked a bunch of clinicians, how would you diagnose this syndrome? And we just depicted a vignette, and we left the directionality of the symptoms vague. So we said something like, Joe is dissatisfied with his body at the moment, and he wants to undertake dietary and exercise practices to move his body closer towards his ideal, for example. And we did a whole vignette and just depicted every symptom of muscle dysmorphia, but left it ambiguous. And the overwhelming majority of clinicians said that this is an eating disorder. And that's really the purpose of diagnostic criteria, to support clinical reality and provide a framework as to what we're seeing in clinical practice. And my fear at the moment is that we're making great strides in recognizing eating disorders in males, and we've removed the amenorrhea criterion, we have removed the BMI criterion, and we are slowly recognizing more and more cases of anorexia and bulimia in males. And we think, though, that there's a much greater preponderance of males who experience disordered eating who don't fit into these conventional criteria, and then maybe best to kind of talk about something like muscle dysmorphia. So my last slide before I wrap up, and I've talked for a bit longer than I said I would. Where to from here? Currently, there's less than 1% of all research conducted on eating disorders which is focused specifically on males. And when we think back to the genetics and the neurobiology underpinning this illness, and imagine that it doesn't skip males, that's a pretty big disparity in what we're focusing on as researchers. And those research trials go on to inform new diagnostic criteria and new treatments, and so we really need to close the gap. We still see males heavily stigmatized with eating disorders, and I think that we ought to start asking the right questions. And I did just see a question on the left-hand side of the screen asking about, are there any measures under development to better account for male eating pathology? And my group is actually validating one at the moment called the Muscularity-Oriented Eating Test, which is the MOE, which is what we all drink when we publish it, hopefully. But that's in development, and that's really oriented towards illuminating the muscularity-oriented eating pathology and indexing how much anxiety the distress around deviating from protein rules goes. So as a field, we are trying to sort of work out what the right questions are to really accurately get at and index male concerns around body image and eating disorders. So I'm aware of the time. I should wrap up here and leave some time for questions. So I'll do that. I'll turn it back over to you, Leslie.
Great, thanks. I don't know if people can see me because I'm having a little trouble with my getting my, yes. Okay, Jeremy's going to help me activate my camera again. So, okay, great. Yeah, well, we don't have a lot of questions out there, but I wondered if you might be able to say some more about how you work toward normalizing exercise and at what point in treatment.
Well, exercise is part of a healthy life. It's a health enhancement pursuit, and we don't aim to demonize the experience of exercise, but we really aim quickly in treatment, very quickly, to place parameters around exercise. And certainly my work, the bulk of my work at the moment is with adolescents, and I really have almost adapted SBT to install parental supervision around exercise and really discuss. And so one technique that I often use is just to draw a pie chart and say to my patients which exercise that you do is eating disorder friendly, which one is connected to values, which one, and so they might say that running in the rain is eating disordered, or doing push-ups after meals is eating disordered. But when I go for a walk with my family or when I walk the dog, that I don't really think about that as a means to manage my shape and weight. So we really try and delineate what's being driven by what cognitions, and we try and install a regime around normal exercise very quickly.
Mm-hmm. Before weight restoration, or?
En route to weight restoration, we think that the weight restoration and the stopping the restriction of foods and introducing eliminated foods is equally as important as blocking the compensatory measures, we think. And so we do that alongside weight restoration, yeah. And it also assists in weight restoration. We have some grave concerns about approaching weight restoration while people are compulsively exercising, and have found that it undermines our efforts to expose, to do the exposure arm of weight restoration.
Yeah, great. Okay. And another question, would you comment on whether family-based treatment would be a useful treatment for children or adolescent males with eating disorders?
Mm-hmm. Yes. I should say yes. I'm about to take up a position with Daniel. It sounds like I should say yes, but no, it is. We have used that extensively at UCSD with males with classic anorexia nervosa, and we found that the conversations differ slightly in that they're oriented towards illustrating the cognitive drivers, and that the exercise might look different, and that the exercise might not be secretive star jumps, it might be secretive push-ups. So there's definitely this sort of comparable efficacy that we see, but it's been modified. We've just sort of spontaneously modified it. And I recently wrote a case study about one case in particular, an adolescent muscle dysmorphia case, which we did adapt FBT to treat this young guy. It looked very different to FBT because the weight restoration piece, in my mind, is the most central part of FBT, and it's sort of so singularly focused on weight restoration. The guy was weight restored. He didn't need to supervise or the intense focus on weight restoration. Where the bulk of that work was focused was supervised exercise practices, and instead of we still installed parental control around meals, but that was really oriented towards reducing the checking behaviors and reducing the protein-heavy content of meals and the restriction of dietary fat. And we just installed the supervision to ensure that there was a nutritionally balanced meal, and that the exercise wasn't driven by the desire to become more muscular. And there was a time where there was no exercise in this case, and then we really reinstalled that very gradually as per SBT.
Right. Okay. Do you have any data or experience on the course of illness for prepubescent males with ARFID in terms of development of AN or muscular dysmorphia?
We don't. I don't myself. I did. I do know though that ARFID, or selective eating, part of ARFID was formerly known as selective eating, and that's been demonstrated to be a precursor to anorexia. And kids who do display selective eating are more likely to go on to develop clinical anorexia nervosa. There's a real paucity of evidence on muscle dysmorphia, so we don't know. I suspect yes, and we see the same. We see the same set shift in difficulties in guys with muscle dysmorphia as kids with anorexia and kids with ARFID. So I suspect that the answer to that would be yes, but we don't have the data to back it up.
Okay, great. And there's a question about one measure regarding adequate weight restoration in females is the onset of menses. Are there key measures of adequate weight restoration in males, like hormonal markers, those sorts of things?
Yeah, well, the value of return of menses is really quite a contentious issue at the moment, as to whether that represents a goal weight or not is, you know, especially when considering the preponderance of cases of anorexia now in females who had a previous history of obesity and may not lose their menses at all during the course of their illness. So I think as a field we're moving away from valuing a return of menses as a marker of psychological recovery, certainly. You know, we don't know much in terms of the physiological markers, of the medical markers of recovery in men with muscle dysmorphia. But in guys with anorexia, if I'm understanding the question right, the same markers would be broadly applicable, like the blood plasma profile would still be illustrative of where our patients are at medically. But I think that there would be no direct comparative return of menses in males, and I know that we as clinicians have that aha moment when we hear our patients menses return. There is no direct correlate, I don't think, in guys.
Right. Well, we've had pediatricians, you know, treatment partners, pediatricians use testosterone and reduce testosterone levels as a way of trying to encourage males to consider what might be happening for them as a result of reduced body weight.
I think that, I mean, there's a bit of evidence supporting that. This markers of bone density and things like that can be powerful indicators as well.
Yeah.
I think we're very much new and developing as a field, and it's a great question. And I think we should be moving towards those kind of answers, which we don't have yet, definitively.
Right. So another participant said, thanks for an interesting presentation. Given the different presentation of male EDs and disordered eating behaviors and motivation in males, in what way could prevention efforts differ for what we do for females, particularly for children and adolescents?
Mm-hmm. I think that, and I did actually, it was part of a very innovative program in Victoria, in Melbourne, which went into elite athlete camps for guys, and we piloted a prevention study. And what we really did was talk about, first of all, that we really aimed to destigmatize the experience of disordered eating in guys, and we really focused on athletes that were involved in sports that emphasize a particular weight category or a body type or display, sort of revealing uniforms. So AFL was a prime example of that. And we really tried to normalize the experience to generate a conversation about what it means to be worried about your body and what it means to be worried about how your body looks rather than how it performs. And we really tried to sort of normalize and provide a safe place where this could be discussed. And in terms of prevention, we're still very, very new. This is I'd broadly categorize that more as a destigmatizing effort rather than prevention per se. I think that prevention efforts might be well served to focus on what balanced eating looks like for guys and what healthy exercise versus appearance-oriented exercise might look like, and also illustrate some warning signs. If you are finding yourself checking labels and checking macronutritional content, or if you're fastidiously calculating how many reps you can do in the gym, when you did it, what angle you did them at. Those are some kind of some concerns that should be broadly preventative.
Sure. And well, based on what you said, I'm guessing there aren't any developed manualized early intervention programs for males with body image issues. Do you know of any in Australia or the U.S.?
No, no male-specific ones. We are in the midst of developing one at UCSD, and I'll hopefully take that to UCSF with me. But there's no specific, there's been no RCTs looking at focusing specifically on males ever. And there's no outcome data looking at prevention treatments for males, prevention programs for guys.
Okay.
Which really illustrates how far behind we are, I think.
Yeah, definitely. Just one more question, Stuart. What do you say to your adolescent clients and families about protein supplements, given the increasing popularity in the community and wide use by people of all ages?
That's a very good question. And I'm glad you skipped Anthony's question, by the way.
I did.
That's a very good question. And in America, it's very popular here in Southern California, and the FDA here, they have no jurisdiction over what goes into protein supplements. It could be literally anything in there. So we try and sort of give some psychoeducation about there not really being anything in there that might support muscle growth. We see this as a compensatory behavior, though, and we see this as a means. So we see the psychological function of this behavior almost as any physiological effect. And so we really know that this is part of a cluster of symptoms that can go on to escalate. And there's also an absolutely normal level of supplement use. And so we really try and educate families about where the line might be, and if there's any anxiety about protein supplies running out, or if one protein powder progresses into a protein powder and a pre-workout powder and another powder, we start to check that pretty quickly in our adolescent guys.
Great. Okay, it doesn't look like there are any more questions, but there have been a lot of thank yous and saying what a great presentation it's been. So thank you very much, Stuart. It has been very informative.
Yeah, no, thank you, and thanks to everybody who gave their time to such an important topic. And again, thanks to Leslie, Jeremy, and Sloan for the opportunity. And it's for anybody who wants a copy of my slides or who wants references for any of the studies that I've mentioned, I'd be very happy to do so. And I trust that Leslie or Jeremy would direct any inquiries to me, and I'd be very happy to supply any materials.
Great. Thank you so much. That's really helpful.
All right. Thank you, guys.
Okay. Bye-bye.